So this symposium will be chaired by John Kellum from Pittsburgh, USA, and myself from Sabadell, Spain, and is a symposium focused on the new biomarkers for early risk assessment and management of acute kidney injury. And the first presentation will be done by my co-chairman, John. John will give us a talk on acute kidney injury risk assessment in critical ill patients. There are new things, new information on this that I think are very relevant for the care of critical ill patients in our ICU. So John, thank you for coming.
Thank you, Antonio. Very nice to escape the bitter cold in North America and to be here in the land of the eternal spring. It's a pity I can't stay longer. All right, so I'm going to talk about a couple of new biomarkers that have recently been discovered and validated and verified and quantified and validated again. And I'll show you all of that. And I'll show you on a little bit of the backdrop in terms of risk assessment in general and why it is essential, why the KDIGO guideline in fact begins with risk assessment rather than simply trying to treat the existence of acute kidney injury. It's important to note that to disclose that I have consulting and grant support, and I have some intellectual property. It's unrelated to what I'm going to show you today, but some other biomarkers of recovery have been licensed by my university to the company that makes the biomarkers that I'm about to show you. But I have no intellectual property. I have no stock. I might buy some, though. It's actually thinking about that. But anyway, these markers, which were published in this article that came out in Critical Care last year, were sort of a novel way of looking at acute kidney injury. So rather than start with a model system, start with an animal model, start with biopsy specimens, start with tissue, the way you discover biomarkers, for example, in cancer. You take a tumor, and you see what molecules are upregulated in that tumor, and then you see whether you can detect them in the plasma. We don't have that option in acute kidney injury. We don't really have tissue most of the time, and our animal models historically have not been that great. So we began instead to ask the question, well, maybe the patients could tell us what markers would be best. And so we enrolled in a set of 3 discovery cohorts. We enrolled several hundred patients with a wide range of different etiologies and different risk factors for developing acute kidney injury. We included patients with sepsis, patients that had trauma, patients that had undergone various surgical procedures, etc. And we pooled all of these data from all these patients, and we ran about 340 different molecule assays. So it was not a totally unbiased proteomic analysis. It was a candidate marker analysis, but there were 340 different candidates. And of those 340 different candidates, many of which were very tangentially at best associated with anything to do with the kidney, but were on the list because they were associated with various pathophysiologic mechanisms that might apply. And the 2 molecules that made the top of the list were then validated in a separate validation study, and that was the Sapphire study. And so what we did was we went ahead and enrolled 744 patients in a validation study, and we looked at the development of acute kidney injury. Now, we decided beforehand, in fact, we even decided back here, that the endpoint that was of most interest was the development of moderate to severe AKI, stage 2 or stage 3. You might have argued that stage 1 would be important too, and I don't dispute that, but you need to draw the line somewhere. And so I could show you sensitivity analysis, which include all of stages of AKI, but the primary endpoint was stage 2 and stage 3. And the reason for that is that it's pretty unequivocal that stage 2, stage 3 AKI are causally related to both short-term and long-term outcomes. You wind up dead or on dialysis or with persistent renal dysfunction in patients that have stage 2 or stage 3 AKI. Stage 1, some do and some don't. So that was the primary endpoint. And we showed that the 2 top markers that were found in the discovery cohort, TIMP2 and IGF-BP7, not household names and certainly not molecules that I was in any way familiar with prior to this discovery, and the composite, the multiplication of the 2 together, which really in this trial don't show much of a separation from just urine TIMP2, but I'll show you why you still want to use the 2 together. These 2 markers, TIMP2 and IGF-BP7, were clearly head and shoulders above all of the other markers that had been looked at for the diagnosis of acute kidney injury, for the risk assessment, prediction of development of acute kidney injury in patients from a variety of different populations. For this meeting, I also am showing you the results broken out for sepsis patients. So about a third of the patients or so had sepsis in these trials, and the relationship between these markers in sepsis-induced AKI are clearly shown again to be superior to others. You can see there's a little bit of a difference when you look overall. Things like plasma NGAL is not a very good marker in all patients, but it's a much better marker in sepsis-induced AKI, probably because it's a better marker of severe sepsis in general. It reflects higher inflammation in the plasma, and higher inflammation in the plasma, as you'll hear me talk about later this afternoon, relates very closely to the development of AKI. But these markers here still remain at the top of the list, and we're superior to the other biomarkers that are known to be associated with AKI. So what are these markers? So as I said, tissue inhibitor of metalloproteases 2 and insulin-like growth factor binding protein 7 are not necessarily molecules that are household names. And so I began to look at the list of things that these markers were associated with, what biological processes they were implicated in. And of course, thank goodness we have people studying cancer, because occasionally they cure certain forms of cancer, but also they provide us with enormous amounts of data on the biology, the cellular and molecular biology. And so almost everything we know about these molecules come from the cancer literature, where they're both implicated in epithelial cell cycle arrest. And so that caught my eye, because only just a couple of years ago, Joe Bonventry from Harvard published data showing that persistence of cell cycle arrest in epithelial cells in the kidney, renal tubular epithelial cells, are associated with the progression from acute kidney injury to chronic kidney disease, and through reasons that we can talk about, but largely related to just the development of senescent epithelial cells, which then attract fibroblasts. So that cell cycle arrest story caught my attention, and we began to dig into that a bit more. And so what is this all about, and what does it have to do with kidney injury? Well, it turns out that if you go back to your sort of high school biology, you'll recall that cells go through the cell cycle. And most of the cells, even rapidly turning over cells like your gut epithelium or your renal tubular epithelium or your skin, most of the cells are not in the cell cycle at any given time. About 90% of them are at G0. But the 10% that are rapidly dividing, or that are in the cell cycle, can stop at 2 checkpoints. There are some minor checkpoints, but the 2 major checkpoints are between G1 and S phase and G2 and mitosis. If they check themselves here, it's because they want to be sure, the cell wants to be sure that it can enter a energy requiring, an intensive, expensive, and potentially dangerous step in the cell cycle. And the cell wants to be sure that it can survive that. I tell my recently married daughter and son-in-law that reproducing is expensive and potentially dangerous, and that's true for cells as well. And so they check themselves to make sure they have enough energy in their bank account, to make sure that they don't have any DNA damage, because if they have DNA damage, the cell will undergo apoptosis. So it checks itself. So it's an early alarm. It's actually the earliest alarm that there's a problem. The cell thinks it has a problem. And so if we can detect evidence that the cell thinks it has a problem, that's actually the earliest possible place to look for potential of injury that hasn't yet even occurred. There's no injury, there's alarm, there's this stress on the cell. So that was interesting. I thought, geez, if we could detect an alarm, that would be really helpful. And then it got even more interesting because we discovered that these 2 molecules, TIMP2 and IGFBP7, basically together encompass almost all of the stresses that epithelial cells could undergo, including things like UV radiation, which presumably is not a big deal for renal tubular epithelial cells, but oxidative stress, damps and PAMPs, chemical exposures, a variety of things. Now, not all of the molecules are stimulated by, not both of the molecules are stimulated by all of these, but together they pretty much cover the range, which means that if you're trying to find a marker or a couple of markers that would work in a heterogeneous exposure profile, these markers have that potential. The second thing that was interesting was that they signal not only in an autocrine way, stimulating the cell itself, but also in a paracrine way. They spread this alarm across cells in the neighborhood, which was really interesting, as I'll talk more this afternoon, because that leads to an implication about how isolated renal injury can produce very dramatic changes in function. And as I said, this fits very well with work from Joe Bonventry and his lab from just a couple of years ago, and ties it not only to acute events, but also late fibrosis. Interestingly, a very short episode of cell cycle arrest, as you would predict, because the cell is trying to defend itself, should be beneficial. So if you go into G1 as a cell, and you stay there for a very short period of time, and then drop either back into G0 or progress into the cell cycle, that's fine. You're lying low, staying out of trouble, and then you're back in the cell cycle. If you persist, though, in cell cycle arrest, that actually leads to apoptosis, and that's a bad thing in general for epithelial cells to undergo. However, even though it might be good for the cell to protect itself, that alarm going off is something we can sense and try to facilitate that protection. Maybe by taking away a nephrotoxin, maybe by treating sepsis, maybe by resuscitating patients. Now, these markers not only correlate with the risk of KDIGO stage 2 or 3 in the next 12 hours, and we chose 12 hours, by the way. We chose 12 hours, by the way, because in an ICU environment, you cannot possibly predict events with any accuracy beyond about 12 hours, because the next day, at 24 hours, all kinds of new things happen. Patients get new exposures. You can't expect any marker to predict things going out 24, 36, 48 hours. So 12 hours is a reasonable time window, and it gives an intensivist time to react to the patient. Not send the patient home, for example, would be a good reaction. Taking the patient off a nephrotoxic drug they don't need would be a good reaction. Looking for a source of sepsis would be a good reaction. But these markers also correlate in the same sort of relationship. This is the probability of developing this composite endpoint, which is death, renal replacement therapy, or persistence of elevation of creatinine, related to the composite score of the markers, the two markers multiplied together. And you can see that they really have a relationship to long-term outcomes as well. Now, you can notice that there's begins to be sort of an inflection point down here, and maybe an inflection point up here as well, although it's hard to tell. So we chose marker cutoffs that were related to high sensitivity, and we chose a sensitivity as high as we could go while preserving some specificity of at least 50%, and we chose a high specificity while preserving some sensitivity. So those are the two cutoffs that we chose based on sensitivity and specificity, and we then validated those in a subsequent study, which is the Opal study, which shows remarkably similar receiver-operator characteristics. We then conducted, in this last trial, we conducted the Topaz trial, because in the US, you need to have yet another trial to get a diagnostic approved by the FDA. So we conducted the Topaz trial, and this is our latest trial. It hasn't been published yet. The unique thing about this is we were forced by the FDA to adjudicate the endpoint. It wasn't good enough to have KD go stage 2, stage 3. We had to have an expert panel adjudicate every case. And that's actually what was done for troponin I, or troponin before that, and even CPK. So it wasn't unreasonable, although I thought that it was quite a burden for a clinical trial. And so we adjudicated every one of these endpoints. And what we found was that the receiver-operator characteristic curve actually went up. It went up from about 0.8 to 0.82 when you adjudicate the endpoint, again suggesting that even when you make it even harder criteria, the markers actually perform even slightly better. Interestingly, these are the concordance across adjudicators. So we had 3 adjudicators, and we said when all 3 adjudicators say there's no AKI, the markers are down here. When all 3 say they have AKI, the markers are up here. But when there's one person who says, nah, I don't think there's AKI, and 2 say there is, the markers are up here. And when there's discordance in the other direction, the markers are here. Notice how the markers are telling you something even when cases are discordant. The markers tend to side with the majority, which I thought was really quite interesting, right? You have 2 experts, and one says no, and the marker says, nah, I go with the majority rule. And it does so in both the high and the low, the concordance with, or discordance with, and the discordance without. These are the relative risks based on either 1 cutoff or 2 cutoffs. And you can see there's a substantial increase in risk of AKI when the markers are elevated. Just to give you some sense of what that means, you start from a baseline risk of about 1 in 25. In the next 12 hours, a patient with a low risk, less than, biomarker concentration is less than 0.3, will have a 1 in 25 chance of going on in the next 12 hours to develop stage 2 or stage 3 AKI. If they're above the 0.3 cutoff, they have a 1 in 3 chance. Now, clinically, as a clinician, that's a huge difference, right? A 1 in 25 risk, I can almost tolerate that. I can almost say, well, let's just keep an eye on the serum creatinine, but the patient doesn't need to stay in the ICU. Keep an eye on the patient, but the patient doesn't need to have a change in their medication. If it's a 1 in 3 risk, though, of developing stage 2 or stage 3 AKI in the next 12 hours, that's something that I have to react to. So what would I do? Well, I would do these things in the KDIGO guideline. I would discontinue nephrotoxic agents that I can discontinue. I would ensure volume status and perfusion pressure, and frankly, I wouldn't give starch to a patient like that, at least if I didn't have any reasonable option, like albumin. I wouldn't give saline to that patient either. I'd give a balanced crystalloid. I'd consider doing functional hemodynamic monitoring. I'd monitor the serum creatinine and urine output. I'd avoid hyperglycemia, and I'd consider alternatives to radiocontrast. Are we doing this now for all? We think we are, but actually if we look and see, we're not. We're looking at patients that are high risk for AKI, and we're not doing these things. Why? Because the risk is anywhere from 1 in 25 to 1 in 3. And we don't have a biomarker to distinguish between those, and now we do. What would we do different? Well, if you have a low-risk patient, you could probably just monitor their serum creatinine and their urine output, whatever the standard is. Once a day for creatinine, once a shift for urine output, maybe. If they're at the high-risk group, maybe you should be monitoring them more frequently. And if they're at the very high-risk group, above the 2.0 cutoff, maybe that's a patient that needs very frequent monitoring of creatinine and urine output. Ensuring volume status, and I don't really agree with the CDP cutoff here necessarily, but suffice it to say you'd pay more attention to the volume status in a patient at higher risk of AKI. Avoiding nephrotoxic agents. What about discharge from the ICU? I mean, I think there's lots of times when you're on the fence about a patient who's got a little bit of elevation in their creatinine, but they don't have AKI, and you think, well, is this going to evolve or is this going to get better? I've resuscitated the patient, they're post-cardiac surgery, lots of patients have a little bit of increase in their creatinine. Do they really need to have more investigation? Well, if they're at very high risk, then they certainly do. If they're at very low risk, then they probably don't. And then lastly, and this is just hot off the press, but I wanted to show it to you, this is the cutoff performance in terms of 30-day and 9-month mortality. And you can see there persists this relationship. These are the above the 0.3, less than the 0.2, or less than the 2.0 middle cutoff, and this is the high cutoff. And you can see this very striking relationship in the 30 days, which is here, and the 9-month here. So these are telling you something about what happens to patients even at 9 months down the road. So in conclusion, markers of cell cycle arrest appear to be robust when measured for acute kidney injury manifesting in the next 12 to 24 hours. They're validating now using an expert panel, sort of the highest standard for validation. Risk strata above the 0.3 correspond to a relative risk of 8, or roughly going from 1 to 25 to 1 in 3. The underlying biology suggests that there's an alarm phase that we're detecting with these markers, and that alarm phase is before injury has actually occurred in most cases and gives us an opportunity to intervene. And with that, I thank you for your attention.
Thank you very much, John. Is there any question from the audience? May I ask you, do you have any information on the dynamic evaluation of this biomarker and how the fluid replacement can influence on the results? The fluid replacement.
In plasma, yeah. So yes, I have information on both of those. I'll take the second question first. These are not plasma markers. They might be in certain situations where there's enough alarm going off in the kidney to leak out into the plasma, but there's not much correlation at all between plasma levels and urine levels. And so they don't appear to be good plasma markers of kidney injury. They appear only to work as urine markers. In terms of and they're not filtration markers, so there's no correlation between the plasma concentration and the urine concentration or the GFR. There's some evidence that NGAL works partly because it's kind of a combination of a filtration marker as well as an injury marker, because the markers are filtered at the glomerulus. The first question that you asked is an intriguing one about the dynamic processes, and we don't have all the data yet, but in our studies so far, these markers are released, they're rapidly released in the setting of injury or alarm, and they don't persist for very long. So they don't persist for more than about 24 to 48 hours. So if you measure again and again and again, you sometimes find cases where the markers are low, despite the fact that there's established acute kidney injury, and that's because you've missed the window. But frankly, you don't need a marker of predicting acute kidney injury in someone who has acute kidney injury. So in the absence of acute kidney injury, the presence of these markers seem to be indicative of this alarm and therefore prediction of acute kidney injury, but they don't persist in a way that would allow you easily, at least, to monitor what goes on.
Any question from the floor? No? So thank you very much, John. And we continue on the program. Next presentation is again for Didier Payen from Paris, France. And Didier will have a talk on the role of perfusion and inflammation in acute kidney injury.
Thank you. Mr. Chairman, John, Antonio. So the question you asked me to discuss is the acute kidney injury risk assessment. And finally, in this risk assessment, what is the role of the perfusion or the hemodynamic versus inflammation? And I will try to give you some ideas about that. Okay. So first of all, you should remember that this organ is consuming a lot of oxygen because of the active processes to do the job of a kidney, maintaining the homeostasis adequate. The tissue itself doesn't need a lot of oxygen, but the tissue is working 24 hours a day, which is not typically the French tissue, because normally we don't work 24 hours a day in France. But the kidney does, which needs a lot of energy because he has to filter and reabsorb a lot of things, especially the sodium, which is an active process. And you see the different localization at which this active pump are working well to reabsorb the sodium and doing some ions exchange. And this oxygen consumption is increasing the more you work for doing the job as a kidney to keep the homeostasis okay, the more you consume oxygen. So in other words, we can imagine that if you have a situation where the kidney is doing a lot of work to keep the homeostasis well, then if you are not providing sufficiently enough oxygen to the tissue, maybe you can have more frequently an acute kidney injury, and you are at risk of this at least. The risk might be amplified by the other systems which are supposed to modify the kidney function and the pump functions. And these systems are the sympathetic system, the renin-angiotensin system, the ADH or vasopressin system, the prostaglandins, EMP, and many others. So we know this very well because a couple of years or decades we learned a lot about the hormones controlling the work of the kidney, but we don't know too much about the mediators involved in the inflammation, and John nicely questioned this and tried to put in the global scheme what's going on for the cells and the inflammation. Then if you have a deficit of oxygen delivery to the tissue, we can imagine we are in a very risky situation for the acute function. So if we go to this risk, what means risk? Honestly, initially it appeared for me more or less a concept, a risk of acute kidney injury, a risk to die, a risk for the plane to crash. Yes, we understand the risk, which is something which may occur, but which is not so frequent finally. And the difficulty is to get something which is telling you, take care. This is a risky period for you. Stay at home because, you have a bad, horoscope. And the people are telling you that you have bad luck for the moment, so stay at home. You're at risk. It's a difficult concept for me. Anyway, we have at least some two scoring systems, the refill and the Acute one, which are stratifying this in risk, injury, and failure. And that makes sense to try to apply this regularly and look at the database when you have a lot of patients, if it makes sense or not to look at this risky situation. So if we go to the risk, there is something which is emerging more and more. This is the concept of the subclinical acute kidney injury. It's a risk, subclinical, then injury. Maybe there is a step between the risk and the injury, which is the subclinical. Subclinical means that you are not seeing yourself with your eyes, with the urine bag, maybe with the routine lab exams. You are not able to detect well. So you need biomarkers to know that. And then if you look at the no acute kidney injury with a scoring system negative, no biomarkers elevated, so you are in a good way, normal. Then you move to an acute kidney injury with tubular damage, because the kidney is a complex and heterogeneous tissue. Then you can have a scoring for function which is negative, but you can have some positive biomarkers. And John told us that the NGAL might be, at least for acutely inflamed situation like sepsis, might be a good candidate sometimes, but even it's not perfect. So this is biomarker plus and scoring system negative. Then you can get some acute kidney injury with function loss. The kidney doesn't work well. You get the scoring system positive, but the biomarker is negative. So we have this situation sometimes. And then if you have both the scoring system for function, which is positive, and the biomarker, which is positive, then you have an acute kidney injury with function loss and tubular damage. So that globally the kidney is injured. Between this, it seems to be a more intellectually built, but it's true, it corresponds to different steps of the evolution. Then as a clinician, you're looking for the risk factors. Some you can do something to prevent, some you cannot. And most of the time, you cannot do a lot of things to prevent the risk factors such as comorbidity. We are old, no, I am old, you are young, but I don't have diabetes, but you can have a diabetes, so you have this. Hypertension is fixed, so all this comorbidity situation cannot be changed. And the type of procedure you are supposed to suffer or to be injured, like major surgery or trauma or whatever, it's done. You cannot change this. If we look at the modifiable risk factors, so that are the factors you can perhaps do something to protect or limit the consequences. Of course, when you know the surgery will go on, and the surgery is a severe one, you can do some pre, intra, and postoperative attitude or strategy to limit the risk. And that's what's been done for many years, saying that the optimization in the perioperative period of time may change the outcome of the patients, including the acute renal failure or the kidney injury. You can avoid a drug toxicity and you can do some supportive therapy. I don't know what kind of fluids, because Gilali is not saying no for the macromolecules. And John said that if you can do well with something which is cheaper and safer, why not using the cheaper and safer instead of the one which is more expensive? And John said that it's better for everything in the kidney because it protects a lot of. So finally, I don't know, but give fluid is probably good when you want to prevent or to limit the risk. If you go to this preoperative predictors of postoperative acute renal failure, you see almost all these factors, which are the stronger parameters associated with the occurrence of acute kidney injury. You can do a lot of things for this, so you have a risk assessment which can be done easily before in the context of the patients. During the surgery or the process of the ICU, finally, if you are looking for the preoperative hemoglobin and the probability of acute kidney injury, you see if you are becoming anemic, 12, 10, 8, you see the probability goes up to get an acute kidney injury. So clearly, the oxygen carrier is an important issue to prevent the acute kidney injury. Here you have the perioperative red blood cells transfusion. It is going in your sense, Jan. If you give some kind of small amount of red blood cells means no bleeding, so you don't have a lot of probability for acute kidney injury. If you are bleeding a lot and you should transfuse a lot, of course you have a high risk of hemorrhagic shock and kidney injury. So finally, is it a perfusion issue or is it an inflammation issue? We have this, which is the final evaluation you do, the risk or the diagnosis of acute kidney injury, but we have difficulties to know if it's related to hypoperfusion, which means hypooxygenation of the tissue maybe, versus the inflammation. Then, if you look at this, and Jan, you recognize this slide you made with Mathieu Legrand, and this is something that we should remember. This is the proximity between the different cells, which are very important in the kidney. You get the tubular cells, and very close, you get the endothelial cells, and very close, you get the circulating cells, red cells and white cells. And all of these are very, very, very close together and they can talk together all the time. Then if you have an injury, whatever the injury would be, you can have here some abnormal epithelial cells or tubular cells which are becoming necrotic or apoptotic, and this is also an abnormal permeability at the endothelial cells, and the white cells are supposed to cross over, and then the white cells, PMNs, macrophages, or monocytes or lymphocytes, can go in the interstitial space with consequences both at the vascular level and at the epithelial level. And this vicinity is very important to be considered when you have inflammation and perfusion combined together. So John did a very nice review, and this is the first page of the Shock Journal. I saw the scheme, and it's very interesting because they tried to put together, to reconcile the hemodynamic theory with the inflammation theory. And the clinical conditions during which we have the most frequently the acute kidney injury, sepsis, major surgery, heart failure, hypovolemia, are almost always associating hypoperfusion or at least shock. Then, at least when I was young in the faculty, it was always said that, you know, acute kidney injury comes from hypoperfusion. If you improve the perfusion, then you don't have any more ischemia in the kidney, you avoid the acute kidney injury or the renal failure. And finally, this is not probably so true. But in acute kidney injury, when it comes, when it occurs, in the absence of other signs of hypoperfusion, does it exist? So you have a lot of patients with no hypotension, no low flow, no dehydration, who have hypoperfusion avoiding, but they have an acute kidney injury. And it's not related to toxic drugs and the contrast material or whatever. And then this is not really related to the kidney hemodynamic or low flow for the kidney or whatever. And in vitro studies show that the cardinal feature of sepsis-induced acute kidney injury can be reproduced after incubation with plasma from septic patients. That means that in the plasma of septic patients, you have factors which might be toxic for the kidney, whatever the perfusion is. So this is a filtration of the so-called DAMPs and PAMPs, you know, these molecules which are coming from the bacteria or coming from the cells injured in the different conditions. You filtrate this and you stimulate by the receptors to the DAMPs and the PAMPs, TLR4 for example, you stimulate the reaction of the tubular cells. So by the urinary pull, you can have a toxicity to the epithelial cells. On the other side, you can have, in addition to the filtration, of these pumps and dams, you can have through the vessels some activation of inflammation. Then you have a combination of perfusion and inflammation related to the two sites of injury in the kidney, the urinary one and the vascular one. And these are crossing over and then may change or be toxic for the epithelial cells, creating some reactive oxygen species release, which are bombing all the normal and abnormal cells. And then the two, the perfusion and inflammation, are playing together. If we go back to the clinic, if we admit the idea that the hypoperfusion is a major point to explain the acute kidney injury for most of the cases we see, if hypoperfusion is a major point, we should see the lesions in the histology down on biopsies in human kidneys. And then I love this paper because Nicolas did biopsies, fresh biopsies in patients dying from septic shock. And what he showed that the kidney lesions in these recently dead patients from septic shock, the kidney lesions in septic shock go beyond those associated with simple acute tubular injury, which means ischemia, notably capillary leukocytic infiltration and apoptosis. And this was in 2010, before the publication of all other biomarkers related to inflammation. And I love this, and you have only few lesions related to ischemia. So that's a major point. The last issue would be the role of renal perfusion pressure. Is it really a big marker? What is the role of the volume and flow for the kidney? And what are the role of the presses? Because finally, if I understand this morning, so having 75 or 85 for blood pressure does not change the outcome, except if you have hypertension before, you should give more pressures to get a higher pressure, which may prevent the renal failure. That's what I heard this morning. And this paper apparently will be published soon. If we look at this paper, the group was targeting a mean arterial pressure of 65 or 85, which is almost the same idea that Pierre discussed this morning. And you see the urine flow here, and the serum creatinine and the creatinine clearance. In this paper, if you target 65 or 85, you don't have any difference for the urine flow. So higher pressure does not improve the urine flow. The same for the serum creatinine, which was not reduced by the elevation in blood pressure, and the creatinine clearance was not modified by the pressure increase. So finally, pressure correction or hypotension correction does not change too much the renal function in these patients. In the paper we published in 2012 in PLOS ONE, we look at the index that Massimo developed in the JAMAS paper, the index which is the vasopressor dependency index, grouping all the vasoactive drugs with some coefficient. I don't know how you build this, but it's very efficient, and I love this index. And finally, if you look at the value of this index in the patients with no acute kidney injury, mild acute kidney injury, or severe kidney injury, you don't have any difference between the two. In other words, severe or not severe, the intensity of cardiovascular support is exactly the same, which is against the perfusion theory. Something that we recently published concerning the congestion and maybe the venous pressure, not the volume stated, but the venous pressure might play a role. You see the correlation here between the right atrial pressure level and the risk of acute kidney injury. And you see here from 8 to 12, you get something which is the place we are putting the patients most of the time, and you have a nice linear correlation between the level of CVP and the acute kidney injury. So maybe the lowest for CVP would be the best. And you see here the CVP is associated with the occurrence of acute kidney injury. So reduce the CVP, it might be a goal in the future. And the last argument, which is important, if it's a perfusion issue, you can observe at different evolution time of the patient, acute kidney injury starting very early, or a couple of days after, or after the end of the first week. And then we look at this, and we are very surprised to see that you have, in the first 2 days after your arrival in the ICU, no ACI, moderate or severe, and this is fixed for the rest of the days. In other words, very few patients are patients moving from no ACI and having an acute kidney injury in a couple of days after. The game is fixed very early in the story of the patients, and then when it's fixed, it's fixed. And the role of inflammation is probably very important to explain why you have a very early acute kidney injury and not so frequently a late one. It's because inflammation is present at the initial phase. Not inflammation for the number of leukocytes, not inflammation for HLA-DR, which is the synapse between innate and adaptive immunity. So you see no acute kidney injury in a gray, mild kidney injury, no black, severe kidney injury, no difference between the three. But if we look at the other markers, IL-6 was low in no ACI, moderately elevated in mild acute kidney injury, and very high in acute kidney injury. So this is the day 0 when they arrive, and then they go down rapidly after that. It's true for IL-10, so the pro and the anti, which means that the process of inflammation itself, not the pro or anti, the process is activated more in the patients having acute and severe kidney injury. It's true for the MIF, which is also a cytokine, a more complex one, you get the same result. So finally, we can say that the perfusion might be an issue which may amplify the acute kidney injury occurrence, but the essential is coming from the inflammation. I think this is the end of this. Just to tell you that the subclinical one, so should we use 1, 2, 3, 4 more biomarkers to detect more early the lesions in the kidney or the risk of the lesion in the kidney? That's a question which is still for me unclear, even we have new ideas with the cell cycle arrest. Thank you very much for your attention.
Thank you, Didier. Is any question? John, do you want to ask something? Yeah, Maximo?
I don't want to be provocative.
Take the micro.
Provoke away. Go ahead.
I don't want to be provocative, but in the times where you have the international, mostly American, choosing wisely campaign, what we should do? Should we ask for these very fantastic mediators in any case, or should we design a sort of algorithm where, and exclusively when we see specific, let's say, clinical parameters, we are pushed to ask to the lab for getting back the results of this kind of parameters?
It's for John, it's for...
For both, you can both. And in addition, that I would like that you answer probably both also, is that you mentioned or we discussed or you present data on the biomarkers, but you didn't mention anything about the combination of clinical risk factors and the biomarkers. If we combine clinical data and biomarkers, are we improving the prediction of acute kidney injury in these patients?
For the, I don't know if John agrees, but for the clinical assessment that this is something we should do more accurately now. Personally, I did not pay a lot of attention for the risk factors, which are the risk factors to get an acute kidney injury. So finally, this is a comorbidity, I would say. On top of this, if I have an injury which is a small one, then I can't precipitate the failure of the kidney because of the comorbidity. For the other people with no comorbidity, I need a big injury to get an acute kidney injury, and then probably the biomarkers for the small injury for the kidney or big one, depending on your presence or not of comorbidity, may change a lot our attitude for the future. I don't know if you agree, John.
No, absolutely, and that's why you can have a situation where we talk about this subclinical AKI, where the markers are elevated and there's no manifestation of AKI. And when you look at who that happens in, it's almost always patients with relatively preserved baseline renal function, and that's because they have a lot of renal reserve. You can donate a kidney, right? So you're young and healthy, you donate a kidney, you lose half of your nephrons, half of your functional renal mass is gone, and your creatinine doesn't change. And so you have a lot of renal reserve. You have a lot of chronic kidney disease and your creatinine is already elevated. It doesn't take very much injury to manifest as AKI, and so there is that relationship that you're speaking about. The trouble with risk factors in this field is that the things that are most predictive of AKI are stable underlying susceptibilities, things like chronic kidney disease, age, etc. Those don't help me that much once I've already decided that this patient is at high risk, right? So this patient's in my ICU, they're at high risk. But not all patients that are high risk develop AKI. And so sorting out which of those patients is going to have a manifestation of acute kidney injury in the next 12 or 24 hours is really sort of the thing that I need as a clinician. In the trials that I showed you, they were all high risk. They were in an ICU, they had respiratory failure or cardiovascular, so they were high risk already. And yet only about 1 in 7 of them ever manifest acute kidney injury, even in the course of the 3 or 4 days of observation.
I have a question, maybe, Mr. Chairman, if you agree, for the audience and maybe for you. And John, you have, I'm sure, an answer for that. Do you think that the fluid we give, especially the one which is giving a lot of acidosis, I mean the so-called saline, which is a low pH, we give a huge amount of this, at least in Europe, versus the so-called balanced lights or crystalloids, which is supposed to give less acidotic load. For you, what is the best or the most dangerous for the kidney with the borderline risk? Is it better to give some acidotic crystalloids, or is it better to give some balanced crystalloids if we don't give too much macromolecules?
So without a doubt, in our human studies as well as in our animal models, we have much worse acute kidney injury with saline compared to balanced electrolyte solutions. Now the reason for that is not completely understood. It's not clear whether balanced fluids provide some salutary benefit or they're just less toxic. Unlike what John has shown with his models, where virtually any fluid that you give, particularly if you give it in large quantities, you see inflammation. We definitely see more inflammation with saline than we do with lactated ringers, for example. And it's likely, it would seem likely, that the relationship, the association between that increased inflammation and the existence of acute kidney injury results in worse extension, if you will, of the damage. At least that's how I interpret it.
So are you ready to say that you will give more frequently the ringer lactate to the people with the risk, non-modifiable risk of acute kidney injury instead of saline?
Well, so I frankly don't see any use for 0.9 normal saline. Now, I may not be allowed to be back in the country saying that, because my countrymen in the United States use saline like it's water. They use saline quite frequently. And I will say I do use it in the rare situation where you have an alkalotic, usually over-diuresed patient who has a true deficiency of both sodium, chloride, and water. And I think it's perfectly fine for that, but that's it. I don't use it for anything else. I think John wants to jump in.
Very short question, please.
It's a comment actually on Didier's talk, although I have got plenty to say on what John has said. But I don't agree with a lot of what you said, Didier, and you know this is very unusual for me, as I love you very much. But I have this problem of having perfusion against inflammation. This does not make sense to me. Hypoperfusion causes inflammation. Reperfusion injury causes inflammation. So that's one important thing. So to say, oh, it doesn't matter what you give, the perfusion is okay, it's not important, it's all with complicated inflammatory molecules, I think is a big problem. Hemodynamic issues is central because it is the prime mover of inflammation. It's my first point. My second point is you are a co-author of a paper we wrote together. And we saw in that it's not what goes into the kidney. Belemo's group has looked too. The renal artery flow, you can keep it completely constant. It tells you nothing. The blood pressure also. These are the clinical parameters. The problem is the distribution of that flow in the kidney cortex. And if you look at saline or any type of fluids, you see patchy areas. And there's a lot of shunting in the kidney too. And this causes inflammation. It is regional micro reperfusion injury which is being induced. So I think perfusion is prime because the longer that micro areas are being hyperperfused, the bigger the reperfusion injury when it finally gets the blood that it needs, is the point I wanted to make.
Thank you.
I can say yes. You are right, we agree even when we disagree. That's true.
Thank you, Didier. It's my pleasure to introduce our last speaker of this session, Peter Pickers from the Netherlands. Will be speaking about risk assessment and how to prevent organ failure.
Thank you very much, Mr. Chairman. Thank you for having me here in Barcelona. So we heard a lot this morning about pathophysiology and pathways of damage. And in this talk, I will focus a little bit more on clinical issues. And I will try to address 4 topics. I will come back to some clinical risk factors to develop acute kidney injury. I will talk about the long-term consequences of AKI in the ICU and also about the role of the kidney in the development of failure of other organs apart from the kidney and the mechanism of action of that. And I will try to finish with what we can do about it. So there's actually very little literature about patients on the ICU and what their clinical risk factors are to develop acute kidney injury. There's only one study in a general population, that's this study, so not focused on patients having cardiac surgery or specific populations, but a general population that is admitted to an ICU. And these authors, they just took a bunch of risk factors that were already known from the literature or common sense that they could be risk factors, and they defined them as described here. And in 10 hospitals they had 316 patients, and they rightly said, well, there's no universally accepted risk factor assessment in these patients, so let's have a look. And what they found was indeed these risk factors do play a role. Age, the older you are, the more likely you are to have AKI. Male, for once, is not a risk factor, but all the other things actually appear to be more common in patients that develop AKI. And if you combine these and you adjust this and you do a multivariate analysis, then 4 independent risk factors, clinically important, remain, and these are sepsis, 3.5 times or 2.3 times the adjusted odds ratio, hypovolemia, 6.2 times, already chronic kidney disease when you are admitted to the ICU, 3.9 times, and diabetes. So these are the main risk factors to develop AKI or when you are a patient that is admitted to the ICU. Of course, there's quite an amount of overlap, and here you can see patients without the development of AKI in dark blue and patients with the development of AKI in light blue. But you can also see that the number of risk factors play a role, and the patients that will not develop AKI have 0, 1 or 2 risk factors, while the patients that do develop have 4 risk factors. So there is some distinct, you can make some distinction, but it's a large overlap. At the same time, the amount of risk factors, so if you just add them up, is very important, and there's almost an exponential increase of developing AKI in the ICU when you have more than 5, 6 or 7 risk factors. So I do think the question that was just raised, that in these patients without any risk factors, they are very unlikely to develop AKI, and I don't think it's any use to measure these new markers of AKI, because it will be a waste of money, the chances are too small. And on the other hand, in patients with all risk factors, 100% of those patients develop AKI. So you don't need a marker, you already know it's going to happen. But still in the middle, these are the patients with 3, 4, 5 risk factors that would be of interest. And this is a subset of patients where measuring a biomarker would really help you knowing if this patient is really at risk or not. And I'm not aware of a study that has combined these clinical risk factors with the biomarkers, but I do think it's likely that there will be an additional value of those biomarkers when you do it this way. So about the long-term consequences, and I think that's also very important and something that is not completely recognized. And we do have some good data from a Danish cohort. In 2012, they published 1-year mortality of patients that developed AKI on the ICU. And you can say, well, the risk group is just a very small increase in creatinine, or is just a decrease in their urine output, is not really something to worry about. You can see what their mortality is, and risk, injury, and failure already within 60 or 90 days after leaving the ICU, their mortality is about 4 or 5 times higher. So even a very small amount of an increase of creatinine or a decrease of urine output has an enormous impact, in my view, on mortality. And this differences between people with AKI and without any AKI is also persistent. So it's not that at the end of if the follow-up is long enough, everybody dies, but this is a persistent difference. So it's very important also to recognize the lighter forms of AKI, I think. And from the same database, the group now also published last year in Critical Care the 5-year risk, not of mortality now, but of having end-stage renal disease. And this is divided in the group that needed renal replacement therapy during their ICU stay. So even if it's just 1 day on the machine, then you were in this group. And these are the ICU patients that did not need renal replacement therapy during their ICU stay. And you can see that we used to, or maybe you still say to your patients and the family of your patients, well, your husband is very sick with sepsis and he has AKI as well, but don't worry, 95 or 99% of the patients will regain their kidney function, and it is true, but there's an enormous amount of patients, 10%, that will end up with end-stage renal dysfunction, end-stage renal disease. And so if you look at the 90 to 180 days, if you have had renal replacement therapy on the ICU for 1 day or 2 days only, your chances are 165 times higher that you will have end-stage renal disease. And even if you look from 6 months on, this curve is still separating. So even from 6 months on, the adjusted odds ratio here is 6 times more likely to end up as a chronic dialysis patient. So I do think that we should be very aware that this is not a benign disease or problem, even if renal replacement therapy is given only for a short period in the ICU. So we have some clinical risk factors that we can predict renal failure. I've shown you the long-term consequences, and now I want to talk about kidney injury and multi-organ failure of other organs and what the details are about that. And I think there are a few important questions to address. You could say, well, if you're very sick, the kidneys are just one of the organs to fail. So it's just they are innocent bystander or victims as well in the process of multi-organ failure. Or the other issue could be the kidneys play a role in the development of other organ failure, and therefore they could influence that. The other question is, there is an excess mortality in patients with impaired renal function. I just showed you that. And is that just mirroring the underlying disease? More severely ill patients have more kidney disease and more chances to die? Or is this, on the other hand, possibly attributable to the kidney disease? And I will show you some studies that are very nice and designed to try to give you this answer. And the first study is this one. These authors had a database with over 16,000 patients that underwent radio contrast procedures. And 183 patients of those 16,000 patients developed renal failure, defined as indicated. And because the database was so large, they could easily match patients from the database, and they found 177 patients with completely matched, except for the development of kidney injury. And when they then adjusted for comorbidities and everything else, they found that the risk, the odds ratio to die with AKI is 5.5. So it's not other diseases that these patients also suffer from, it's the presence of AKI itself that has an effect on mortality. They're 5 times more likely to die. And what do they die of? These patients die of sepsis, bleeding, delirium, and respiratory failure. And that makes you think, how would this work? So what they correctly state is that renal failure increases the risk of developing severe non-renal complications, and that leads to death. And so it might not be clear at first view that this has directly to do with renal failure, but it does. And you can easily imagine if you think about it. For example, we know that patients with renal failure are more likely to become acidosis. They have a problem with excretion of chloride or unmeasured anions, and this has other effects. They have platelet dysfunction because of high urea levels. There are effects on the immune system. So there are effects on the brain, more likely to become delirious. So I will focus on a few things. First of all, fluid balance in the lungs. We know from observational studies that the more positive, more than 20 kilograms gain of weight, the more likely you are to die. We discussed that already this morning. That is the fact in patients that are not dialyzed without kidney injury, but even in patients on dialysis, it's even more pronounced. So it's not only the fluid accumulation, but also the effect of the renal damage. And it's just one study that, amazingly to me, that looked at the influence of acute kidney injury, for example, on weaning from mechanical ventilation. And it's clear that if you are having AKI, there's prolonged weaning from mechanical patients, even for patients that only fulfill the urine output criteria. So this is likely related to volume overload, of course, and acid-base derangement, typical of renal disease, but it has a consequence for the duration of mechanical ventilation. Well, and as you already know from the ArchNet trial, if we are conservative with fluids, you have a better outcome, a shorter duration of mechanical ventilation, And they were able to do this by giving less fluids, of course. In patients with shock, they had to give some, but still the difference between the liberal and the conservative group was quite a lot, 7 liters on average. And they were able to do this by prescribing more diuretics and giving less fluid boluses to these patients. So it's all coming together that a positive fluid balance is associated with worse outcome. Patients with impaired renal function are more likely to have a positive fluid balance. They take longer to wean from the ventilator, and they have a higher mortality. Now there's some animal data that shows that also, apart from fluid and acid-base problems, some direct effects of acute kidney injury. And they suggest that transcriptional changes, for example, in the lung may play a role. So there's a direct effect on pulmonary vascular permeability or leukocyte trafficking, and that's also associated with the development of lung injury. I will not go into that because it's only animal data. So some other ways how the kidneys influence distant organs. Well, we already discussed what kind of fluid would you give to somebody with some level of acute kidney injury. And we know that patients with kidney injury have a problem with excretion of chloride, and hyperchloremic acidosis is more common if you have an impaired kidney function. There's accumulation of unmeasured anions. Albumin is important. And this acidosis has consequences. And therefore acute kidney injury may have these effects. Disturbances in sodium and disturbances in potassium are all important, more likely to occur in patients with AKI and leading to other consequences for the patients. I want to focus on one more thing, inflammation and immunity. It's an interesting thing that patients with AKI, 1/3 to 2/3 of these patients, they die of sepsis. And you may say, well, maybe they came with sepsis to the ICU in the first place and they developed their AKI as a consequence of that, and they are still immunoparalyzed and more likely to have a secondary infection, and that's why they die of sepsis. But I found a study that shows that that's not the only answer. And as this study, they looked in patients that were operated, open heart surgery. So nothing to do with sepsis to begin with. And their preoperative creatinine clearance is here. So these are the patients with a very low creatinine clearance and normal. And what they show is that there's a completely dose-dependent relation, that the worse your kidney function is, the more likely you are to become infected. And then you can say, yeah, maybe that's true for patients that became infected post-operatively and they developed AKI during that, but they make the same graph now excluding patients that developed kidney injury post-operatively. So these are just really the patients that come in, and if your kidney function is worse, you're more likely to suffer from an infection. So it's a direct effect of the kidney on the immune system. So renal failure, fluid overload, I've not even talked about increased abdominal pressure, decreased preload, low cardiac output, hypertension, etc. It's all one vicious circle that makes it worse. What can we do about it? This is a little bit the depressing part of the talk. What's not working is dopamine. We know that for a long time now, no effect on the highest creatinine or the increase in creatinine or the number of people with the creatinine above 300 or the number of people on renal replacement therapy. So there's no use for dopamine. We already discussed a little bit norepinephrine, and I heard this morning some new stuff. We know that every organ needs a perfusion pressure, and maybe higher perfusion pressure might be beneficial. Some people think that norepinephrine is a poison to the kidney, and there were some very old animal studies that showed if norepinephrine is infused directly into the renal artery, or if you have a model with hypovolemic or hypocirculatory shock, then norepinephrine indeed is damaging to the kidneys. But it's not in resuscitated patients. And if you increase the dose of norepinephrine, you can increase your blood pressure, of course, but you increase your renal blood flow and you decrease your renal vascular resistance. So it's really increasing your GFR that way. And this was already shown by one of the earlier speakers, that if you have a mean arterial pressure of 51 and you increase that to 79, you actually decrease your plasma creatinine and you increase your clearance, of course, if it's that low. We were not sure about how much pressure do I need. So there was once a very small study that compared 65, 75 and 85, and they showed that urine output did not increase any further, suggesting that going above 65 or 70 is not meaningful. But we heard something else today. In the clinic, for the patients with chronic hypertension, so in the clinic is what I do, is that if I know that there's hypertension in the medical history, and the patient's output is decreasing, his urine output with a MET of 65 or 70, I ask the nurse to increase norepinephrine infusion rate and say, let's aim for a mean arterial pressure of 75 for 4 or 6 hours, and let's see if there's an increase in urine output. And if that is the case, then that patient might need that perfusion pressure. And if it's not the case, we go back to our aim of 70 or 65 millimeters of mercury, and then we are finished with that. So I would be interested in the trial that we heard this morning, that the beneficial effects on the kidney was that more pronounced in the patients that had an increase in their urine output during the first few hours on a higher hemodynamic pressure. Maybe some other vasopressors might have intrinsic beneficial effects. A small study again comparing vasopressin against norepinephrine, and if you give vasopressin, indeed you need less norepinephrine infusion, of course, but it was suggested that urine output increased and clearance increased. But in the meantime, we have the very large FAST trial comparing vasopressin to norepinephrine, and it was found that new organ failure, no difference for kidneys, and also renal replacement therapy, no difference. So vasopressin does not seem to work intrinsically better for the kidneys. Also for insulin therapy, the first trials from Belgium suggested that it was beneficial for the kidneys, significant effects, but the NICE-HUMAN trial could not confirm this, and there was no significant beneficial effect of strict glucose regulation. So my last slide is this, a few practical clues. I think that we should be vigilant. If a patient has an increase of creatinine, it should wake you up and try to find out what's happening. We need to exclude pre-renal causes. We need to exclude post-renal causes. For renal causes, you have to look at the sediment, and you can look at electrolytes if the patient is not on diuretics to have an idea about the cause. And I think the things then are to avoid hypertension, avoid nephrotoxic drugs. There's no use to give dopamine. Don't forget to adjust the doses of other drugs that are given, and use enteral feeding, not parenteral feeding. So the conclusions are: diminished kidney function influences outcome, volume overload and acidosis are important, and therefore the kidneys have an influence on the lungs, but also the risk of infection, bleeding and delirium. And we can do a few things, especially in not making it worse. Thank you very much.
Thank you, Peter. I think in the interest of time, we'll let that be the final word, and we'll spare you Dr. Inge's comments.